All right, so it's a pleasure to talk with you today about psoriasis lookalikes, and I'm really going to focus on the TNF inhibitor-induced psoriasiform dermatitis in talking about it. But first, I just want to make some mention about the prevalence. And this has always been a little bit perplexing to me. So in some work we did a few years back, looking at United States, claims-based data on more than 4 million children using our diagnostic code for psoriasis. And there's only one diagnostic code, not like atopic dermatitis where that can be confusing. Overall, 0.13% of children and 0.2% of adults were found to have psoriasis based on diagnostic code. A little bit more in females than in males, and small percentage having moderate to severe psoriasis, more in adolescents, all what you would expect. We just did a similar study, again, updating from claims-based data. No change, still the same percent overall, about 0.13% of children. And everything else, similar. Adolescents having more psoriasis, more severity, in this case, a little bit greater discrepancy than seen in the pre-adolescent children. But you do the math. Every place we see 2 to 3% of all adults have psoriasis. We've heard that 30% of adults say their onset was during childhood. That comes to 0.6 to 1% of children with psoriasis, which is quite different from the 0.12%, 0.13% that we see in the literature. So why is that? Why the disconnect? And I think it's because psoriasis is very much under-recognized in children, particularly by non-dermatologists. Now, this is a study that came out of Australia more than 10 years ago, but it showed that only 9.4% of the children who came in to see the pediatric dermatologist in Australia with psoriasis as their diagnosis by the dermatologist were correctly diagnosed by their referring primary care physician. Now, to me, that's extremely low, but nevertheless, I think it kind of hits it on the mark of what we were just talking about. And what with these diagnoses, they could be atopic or nummular dermatitis, seborrheic dermatitis, tinea, candidal infections, contact dermatitis. Of course, psoriasis can be in many different areas, but the point about childhood psoriasis is, first of all, that we need better education for primary care doctors to be able to recognize this disease, and particularly distinguishing it from other diseases that have very distinct treatment pathways, as well as what we now understand to be immune pathways. So I think one of the problems is that psoriasis in children can look like typical psoriasis in adults, of course, but can also be different looking, and somewhere in between some of these other disorders. Thinner scale, indistinct plaque, more facial involvement in children, including just facial involvement in some patients, and more only scalp involvement. And in fact, about 80% in our experience of children have scalp involvement, which is far more than what's seen in adults as a manifestation. So you could see how that could be confused with some of these as well. So we sometimes will call it psoriasiform dermatitis. And whether that means more typical psoriasis and having some flexural dermatitis, it's really more like atopic dermatitis, or what we often see, which is something in between because of the way that psoriasis can look in children. This has been a histologic term that has come into clinical use. And in fact, the studies out of the same group in Australia have suggested, looking at criteria, that if you're calling it psoriasiform dermatitis, you probably ought to treat like psoriasis, because it's going to respond better to that with taking a little bit longer to respond, needing more potent medications. Now, I'm going to spend the rest of the time just talking about psoriasiform dermatitis from TNF inhibitors. And I will say that when I talk to my rheumatology colleagues, when I talk to my colleagues in gastroenterology, what they keep saying is, we don't know, is this psoriasis that's developing because our patients with juvenile idiopathic arthritis, our patients with Crohn's disease have a known increased risk. So is that just by chance that we're seeing this even though they're on an inhibitor? Or is it this other disease that we're calling psoriasiform dermatitis from TNF inhibitors? So that remains an issue. I will tell you, though, that TNF inhibitor-induced psoriasiform dermatitis prevalence in children is pretty high. There are many series now out there, 4.6% to 12.8% of children with inflammatory bowel disease who are on these inhibitors. Generally seems to be lower with juvenile idiopathic arthritis, and of course, it can be seen as well with chronic multifocal recurrent osteomyelitis. And in fact, in my experience, I see far more being sent in with inflammatory bowel disease than I do with juvenile idiopathic arthritis. And I have had some patients with chronic multifocal recurrent osteomyelitis. And in fact, in one study, the highest percentage relative to being a very rare disease was in CMRO. The median age, if you look across various studies, is about 14 years of age to have this condition. And the median time from starting the TNF inhibitor to developing the dermatitis is in the range of 14 to 34 months. So we're not seeing this right away. We're seeing this in children who are stable on their medication. Concurrent methotrexate, at least in some early studies, was not shown to reduce the risk of occurrence. And this seems to be a class effect, particularly common in infliximab, maybe a little bit more than adalimumab, but a lot with adalimumab, and rare, but reported rarely, with other forms, vedolizumab, golimumab, and etanercept. But what's so fascinating is that virtually all of these children who develop this reaction are doing very well on their TNF inhibitor for their underlying disease. Again, in my experience, most commonly their Crohn's disease. And so there's a great hesitation to consider doing anything that would require change from this highly successful medication for this devastating, life-altering disease that they have. So what are some of the clinical features that can distinguish typical pediatric TNFi psoriasiform dermatitis from typical psoriasis? Well, most patients have multiple sites, but overall very limited body surface area compared to what we often will see with some of our patients who come to see us for their psoriasis. Plaques less distinct, again, part of this why it's a dermatitis looking, more oozing and crusting. And if you culture, greater tendency to have colonization with Staphylococcus aureus. The most common site, certainly in my experience and in that is seen in the literature, is the scalp. 50% to 73%. And that's similar, again, high percentage of scalp involvement in classical psoriasis. But if you look, most of the time this is more inflamed and there's more associated hair loss, which generally is non-cicatricial hair loss. But if severe from this inflammation, it can actually lead to scarring hair loss if not treated. Other common sites that we don't tend to see much in psoriasis are periorificial, about 30% on the face. And then an area that we certainly can see in psoriasis is ears and retroauricular area with a wide range reported at that location. But then we see other things. Truncal lesions that may be small, looking a little like guttate psoriasis, and something that is different from what we usually see with psoriasis. Just keep going. Often on the hands, fingers, feet, toes, thank you, and nails, including with associated pustulosis, as you can see in some of these pictures. And then knees and elbows, very, very common in our patients with typical psoriasis, but here only in less than 20% can occur. And I think if you look at these pictures, you can see that they look like psoriasis. There's no question here, very well demarcated, but maybe a little bit more crusty than what we see in typical psoriasis. Not common, but reported, is this particularly truncal, follicular, pustular, like punctate lesion type of appearance, as shown in this patient and this patient as well from the literature. So this can be part of that. Now, how do we manage this? And this is a complicated algorithm. I'm going to kind of walk you through it and then talk to you about a very recent study that many of us from the United States were involved in and what we saw happen. So with mild psoriasis in general, we can try to continue the TNF inhibitor, but start topical site-directed therapy, topical steroids, topical calcineurin inhibitors, the vitamin D analogs, the topical retinoids. If you have very eczematous weeping plaques, you might want to think about whether there's secondary infection with staph and either start something topical or something systemic. If the psoriasis, the psoriasiform dermatitis, is moderate to severe, then you really have to struggle a little bit. This is going to be less likely to respond to just topicals. So you might think about continuing the TNF inhibitor and adding something in, whether that's something like methotrexate or acitretin, phototherapy, or ustekinumab has been added on to the TNF inhibitor. You might switch to a different TNF inhibitor, and I'll talk to you about our experience with that, but patients often do not develop it again when they go to another one. Or you might stop the TNF inhibitor and just start an alternative agent. And of course, families are very worried about this because they're generally doing quite well. But this can also be successful because in each case, there are agents that might be helpful. So this is management looking across the range of different papers. Sometimes in one paper, only 15% cleared with topical therapy alone, but we just put out a paper suggesting that 50% of patients in the pediatric range can clear. In this other large series, 50% needed to change the biologic either to another TNF or non-TNF inhibitor. And in our series, what we found is that 88% who moved from one TNF inhibitor to another improved, but a third of them, after a mean period of 6 months on therapy, again on that new TNF inhibitor, developed the TNF inhibitor-induced psoriasiform dermatitis. 31% were able to transition off to other medications. Ustekinumab really appears to be a best choice if you can get it and you want to try to get them off of the TNF inhibitor, and based on what we were just talking about. This is a study that reported 40 patients previously treated with the inhibitor for TNF, and 61% achieved clinical remission, 39% with perianal disease, and really does a pretty good job. It may not be quite as effective as TNF inhibitors, but does a good enough job and has the lowest chance then of having them develop this again if you switch them to that. So that's the current recommendation. So psoriasis itself is a comorbidity, as I mentioned, and it is not TNF-induced psoriasiform dermatitis. Are there biomarkers that can help us define this? And there have been studies in the literature suggesting that there might be polymorphisms of interleukin-23 receptor that increase the risk of developing TNF-induced psoriasiform dermatitis after infliximab treatment. And in fact, there is a TNF allele that's also associated with increased risk with other genes, and some of these are mentioned here. We also have published studies from adults with this disease using qRT-PCR of mRNA that's extracted from biopsy lesional skin. And although there's certainly a mixing of the types of cytokine profiles that are seen, it was more of an interferon gene signature seen with the psoriasiform dermatitis than with the routine classical psoriasis. But what about children? Children are different from adults. We know that in so many ways. And this has not been looked at. Honestly, we don't love to do biopsies. We usually make this diagnosis clinically. We don't even want to biopsy a child if we can avoid it at all. So we can use tape strips, and I just want to remind you how valuable this is. So tape strips are totally non-invasive. The problem with getting mRNA from tape strips is that you usually need the whole series of them just to get out just enough mRNA, poorly maintained, very degraded mRNA at that, to do studies. But that's how some studies were done. That's how we worked originally looking at atopic dermatitis. Of course, with further experience, we know that even from one tape strip, you can get enough protein to run proteomics. And we now have panels that allow us to look at a wide variety of immune biomarkers. And if you think about it, proteomic information is going to be more reflective of function than transcriptomic because it's downstream and it's what's actually leading to function. So we can use O-link proteomics with tape-stripped skin from children and find 362 immune biomarker proteins detected in that stratum corneum scale. So we did this with a study of 11 patients who had the psoriasiform dermatitis, 13 with classic psoriasis, and matched controls. And everything in these patients were classic for the expected differences in morphology and distribution. This is unpublished data, and I don't have time to show you all the details, but I will say that we sampled typical non-scalp sites using the tape strips to do this proteomic assessment. And what we found is even in this relatively small sample were clear biomarkers statistically significant that differentiated these two. One thing was that in the psoriasis itself, there was a much, much higher expression of interleukin-17C, an interleukin-17 that's expressed by keratinocytes. And in the TNF-induced Psoriasiform Dermatitis, we saw enrichment for interleukin-10, actually interleukin-4, interleukin-13, which is a pathway, of course, that maybe is leading it to be more dermatitic, and then several other markers, including several interferon pathway proteins. So a limitation, I will say, is that this panel doesn't have interleukin-22, and it doesn't have interleukin-23. And regretfully, these are markers I would have liked to have seen because, of course, interleukin-23 receptor, of course, we just talked about polymorphism, and interleukin-22 in Kelly's work seemed to be particularly important in the skin of children with psoriasis. So perhaps in the future. But in conclusion, psoriasis is under-recognized in children because of lookalikes and the overlap in clinical characteristics, especially in children under 12 years of age, that the TNF inhibitor-induced psoriasiform dermatitis is a common complication of TNF inhibitor use for inflammatory bowel disease in particular, and may require the switch to an alternative biologic, and that so far when we look through the literature, and particularly at the more recent reports, ustekinumab has the best track record if you can change to another biologic if that is required for disease control. And I thank you for your attention.